Okay, so we are recording the session. So for those joining us remotely, we are doing genoderms today. So, Beth, you want to start?
Like you have some acantholysis too.
Acantholysis. And is it restricted to acantholysis?
See.
Are the cells otherwise normal besides being acantholytic?
Yeah, you got some chlorine.
So you have dyskeratosis, and tell me about the color of the rings around the nucleus.
They look mostly red, I'm saying. Yeah.
Mostly red, one might say only red.
So yeah.
So characteristic of Haley-Haley disease is that you have full thickness acantholysis, dyskeratosis, but only ever with red rings around the nucleus. Never clear, never blue, as you would get in other acantholytic dyskeratotic disorders. And then there are lots of secondary change in this. You can see in areas where it's forming villi and comes by its name benign familial pemphigus, honestly, because it can really mimic a pemphigus split in some areas. And then there's a lot of lichenoid change. So this is a patient with Haley-Haley who had a lichenoid drug eruption and ended up looking like your basic TEN patient in a burn unit because their skin barely holds together under the best of circumstances, and then you add an insult and they have trouble.
I see the acantholysis and
and porokeratosis, correct. So center of poro can look like anything. Types of porokeratosis are acquired, like lamellic or like Mobelli. Linear poro is postzygotic mutation or loss of heterozygosity for a gene like DSAP, and then DSAP is autosomal dominant, so, which is where it fits with the genoderms. So we had on Friday, we had a patient with segmental neurofibromatosis that we saw. So Blake, what's the difference to the patient and family planning if it's loss of heterozygosity versus postzygotic somatic mutation?
Well, if it's loss of heterozygosity, it could be transferred, right?
So either way, but what's the chance of passing it on to offspring if it's loss of heterozygosity? 50-50,
Yeah.
right? Because it's autosomal dominant. You've got the gene. It's just that you knocked out your second normal allele in one segment, giving you one monstrous segment, right? Versus postzygotic somatic mutation, where it's sporadic and you just happen to have one segment affected. And then if it's an abdominal segment, you have a risk of gonadal mosaicism, but it's only 1 to 2%. Because your gonads start in your abdomen and then migrate. And then if it's two widely spaced segments, like one on your shoulder and one on your ear, that had to have happened before gastrulation, and then you will have gonadal mosaicism. Because anything that happens before gastrulation sends cells everywhere. Okay, so...
Got a thick horn of exploded granular layer.
You're leading the witness. You're saying thick horn exploded granular layer. Are you sticking with that?
Well, in the other section, not in no up, like right down the very bottom. I thought that was like right that area.
Oh, that area. You got. So, do you think that's epidermolytic hyperkeratosis there?
I don't now. From
No.
that view.
Okay, so tell me what that is, what that is, what that is, what that is, what that is. That one, that one, that one, that one, that one, that one.
Maybe it's like porokeratosis heterotropica.
Tychotropica, that's exactly what it is. So, porokeratosis tychotropica, we've seen patients here with it. It's often a brownish gray fixed psoriasiform plaque on the buttock. And histologically, it has massive hyperkeratosis, pseudoepitheliomatous hyperplasia, and a million cornoid lamellae all lined up. So tychotropica roughly means near your butt or near your anus in Greek. Interesting that the Greeks have a word for that. So tychotropica means near your backside, and that's where it always occurs. And they're gray-brown plaques. Has everyone seen patients at Grand Rounds with it here? Just the third years.
It was 2 years ago that guy
Okay.
came in.
So there you go. Okay, pass that around. That's what every last patient with it will look like. They all look pretty much the same. And the first time you'll miss it, and you'll never miss it again once you've seen it. So we'll pass that around. Okay, so porotychotropica looks a little different from the others.
It's like
I'll do what I can, guys. Okay. So, Rachel, what do you see? And tychotropica begins with a P. PT.
So there's some pigment of the basal layer. There's some.
So pigment in the basal layer, which could be abnormal or could just be that it's a dark skinned patient, right?
Mhm. There's some ortho, kind of compact.
Compact orthokeratosis.
And then there's not really a granular layer.
And then there's really not much of a granular layer, so you're thinking
Ichthyosis vulgaris.
ichthyosis vulgaris, correct. So ichthyosis vulgaris is orthokeratotic with a diminished granular layer, commonly with keratosis pilaris, and which you may see histologically, hyperlinear palms sparing of flexures. Inherited together with atopy in most patients, or in many patients. And defect in,
Flagrum.
yeah, and so why do you end up with hyperkeratosis if you're deficient in flagrum?
You can't make those like granules. The yeah.
And so how do you end up with hyperkeratosis then? It's a retention hyperkeratosis.
So it's not that you're overproducing, it's that you can't shed.
And it's because there are enzymatic reasons in other ichthyoses, like X-linked, you're missing your steroid sulfatase, you can't cleave, and so you don't, it's an enzymatic defect. It's purely mechanical in ichthyosis vulgaris. The keratohyalin granules swell every time you take a shower and then contract, and that swelling and contracting is what pushes your skin cells apart and lets them shed.
Okay.
So if you don't have keratohyalin, you have a retention hyperkeratosis. Okay, how about this?
Some areas of the epidermis, maybe there's some acanthosis here.
There's acanthosis at the side. There's a big ulcer, inflammatory debris plug, and all this stuff up in it. And some of that stuff is vertically oriented, coming right out of the skin here. So what do you think that stuff is?
Maybe some sort of like perforating.
Yeah, perforating disorder. And is it elastic or collagen?
I think elastic.
You are correct, it's collagen. So, vertically oriented being spit out. In EPS, you never have vertical unless it's collagen. Okay, big bundles, vertical is always collagen. So, what in the genoderms, which one, when you get a little needle stick or get blood drawn, do you get a little papule with a keratotic core in it, and everyone in your family gets the same thing?
Curly? RPC?
RPC, yeah. Curly's is inherited with diabetes, and it's basically, Curly's is the same as acquired perforating disorder of renal failure. RPC is the one that's autosomal dominant inherited, where everyone in the family, everywhere they get phlebotomy, and they're going to get a little plug there that perforates. RPC is reactive perforating collagenoses, autosomal dominant.
So we have some pink material. Some of them are kind of parallel and linear.
Pink material, some of them parallel and linear, kind of vertically oriented, forming large mantles around hair follicles and vessels. And is it restricted to the superficial, or do you see it deeper as well?
Yeah, we have some deeper as well. So could be lipoid proteinosis.
And so, of course, it's lipoid proteinosis. What would look most like it, but be superficial only?
Well, at first, I mean, there's colloid milium or amyloid.
So
that looks
colloid
like
milium
that.
and amyloid could look similar and would be superficial. In colloid milium, you'd see clear transition from elastic fibers to the amorphous material. In amyloid, it tends to be fissured and you have red cell extravasation. The other one would be EPP, erythropoietic protoporphyria, would give you only top-heavy, only upper third hyaline deposits that are type 4 collagen as they are in lipoid proteinosis. Any other clues to the diagnosis if you look at the patient or listen to the patient?
Like a horse cry or beaded
So
eyelids.
beaded eyelid is characteristic, and then they talk a lot like this because it's in their vocal cords as well, right? So xanthoma disseminatum and lipoid proteinosis both have vocal cord involvement. And so, given my cough all weekend, I sound a lot like a patient with lipoid proteinosis right now. Okay.
It's like PXE.
Looks like pseudoxanthoma elasticum. So in what way does it look like PXE?
It has those crinkled elastic fibers.
Like little crinkled calcified elastic fibers. In Singapore, they refer to it as chicken floss because it looks like the chicken floss they put on eggs and eggplant and other things. But what if this is from stria of an older black woman who's had multiple kids?
It's calcifying perforating disorder around the umbilicus. I
Yeah,
can't remember this.
perforating calcific elastosis, or periumbilical perforating PXE is the other name for it, but it's not really pseudoxanthoma elasticum. It's a look-alike that happens usually in older black women in the stria. And they always say multiparous black women, so they've got stria, they've had a lot of kids. So that would be your biggest look-alike for PXE. You can get some changes that look similar with calcium chloride burns as well. Calcium chloride is a form of Lyme, and it's not ever supposed to be used to mark playing fields, but occasionally the vendor runs out of chalk and delivers lime, quick lime instead, to line the soccer field and make the lines. And if it's a rainy day, then you end up with 20, 30 players with third-degree burns because it's very caustic when it gets wet on the skin and leaves dermal changes that look like PXE. So that's, that scenario of sports teams, it's happened a lot in Europe and the US. So, the only difference is for them, they'd call it football, we'd call it soccer, but otherwise the skin lesions look the same. Right?
Acantholytic dyskeratosis.
So you have acantholytic dyskeratosis, and every last ring around around the nuclei is red, right?
No, I see some blue right there.
So this then is not Haley-Haley. It's the anti-Haley-Haley, where instead of having only red rings, you have blue rings, sometimes clear rings, and you can have some red ones too. Very patriotic, red, white, and blue. Right? So, and you have both corons and grains in Terrier's disease. But what if that is not Terrier's? What if it is an old guy with tiny little red keratotic bumps? And Grover's disease. And what if it's a young woman with a vulvocrural lesions?
Vulvocrural dyskeratosis.
Yeah, exactly. Which is localized and acquired. Okay. Victoria, you want to pass or play?
No, wait, I will play. So I think it's hyperkeratosis with a lot of necrotic cells. So I'm thinking about like late incontinentia pigmentia maybe.
That's exactly what it looks like. So you have glassy keratoacanthoma-like pseudoepitheliomatous hyperplasia with lots of individual dyskeratotic cells. Things in the differential, Still's disease can look similar with the dyskeratotic cells, but does not get the keratoacanthoma-like acanthosis that's glassy. And the other thing that can look identical is subungual keratoacanthoma. And some things, well, exactly. So some things that occur and look like subungual keratoacanthomas are actually that you're mosaic for incontinentia pigmentia and you're getting the late lesions under your nails. So, which may be why they look so much alike. Right? So there's really question of whether those are two distinct entities or whether subungual KAs are just mosaicism for IP and you're getting the late lesions. How's one of you passing or playing?
I will do my best.
Okay.
There is a compact orthokeratosis and a hypergranulosis. There is there is like formed cells, like emptied cells.
So they certainly have lots of vacuoles.
Yes.
Right?
Vacuoles.
And the granules themselves, are they nice and round? Or are they very irregular in shape?
It's irregular.
Yeah, so they're very irregular, it's all full of holes, and then, not so much in this example, but often there are both red and blue granules,
Yes.
whereas normally the granules should be just blue. So this is?
I don't know.
Okay. Anyone want to help?
Epidermolytic hyperkeratosis.
Yeah, EHK, epidermolytic hyperkeratosis. So epidermolytic hyperkeratosis is seen it can be seen incidentally or seen in bullous congenital ichthyosiform erythroderma, where you get spiky hyperkeratosis in the flexures, as well as widespread gray hyperkeratotic malodorous ichthyosis. In this particular case, it was a linear epidermal nevus.
Oh,
with this change. So if it's a linear epidermal nevus with the change, is there any risk to the offspring? And the answer is yes, because all linear epidermal nevus with this change is post-zygotic. So it's either going to be loss of heterozygosity or post-zygotic somatic mutation. So you look to see is there evidence of disease elsewhere. So in our NF patient, you look for Lisch nodules. If they're past puberty, they should have Lisch nodules. That's almost 100% penetrant, that feature. So if they don't have Lisch nodules, then it was not loss of heterozygosity, it's post-zygotic somatic mutation, and the risk to offspring is very different. In EHK, you're looking for other subtle features of EHK elsewhere on the body. It may just be much more exaggerated expression in that area if it's loss of heterozygosity. If that's the case, it's 50-50. If that's not the case, then it depends where your segment is. Abdominal segment has much greater risk of having gonadal mosaicism. So, when I was a resident, all the textbooks said not inherited, just incidental curious finding in LEM. And then there were a series of lawsuits where there were parents who had kids with disease that was not just a linear epidermal nevus, but horrible widespread ichthyosis. And
it's like the fat is really high in the
the fat is pretty high, right? In fact, you don't have a whole lot of the dermis, so it looks like the dermis is hypoplastic, one might even say. And so Gold syndrome, what's the other name for Gold syndrome? Focal dermal hypoplasia is the other name. It's not really a hypoplasia, it's actually a neogenesis of fat that squashes all the collagen out of the way, because it starts as perivascular fat and then spreads. And Gold syndrome, what's your patient typically going to look like? Male or female?
Male. Females.
Female. Why is it never males?
It's lethal.
Because they're dead. Yeah. So it's lethal in males. It's a lethal gene, right? And so the males don't survive, right? Females only survive by lionization. So every every other strip of their body through lionization, random lionization, every 50% of the strips of their body are affected and 50% are not. So do they look zebra with equal stripes? No, why not? Because it's a lethal gene, right? So that tissue dies. So you can tell by looking at the Blaschko segments. Why in segmental neurofibromatosis, that area, did it look like a normal Blaschko segment or was it too big?
It's pretty big.
It was really big, the area. Why? Because it's a tumor suppressor gene that was knocked out, right? You knock out a tumor suppressor gene, your Blaschko segment's too big. If it's a lethal gene, your Blaschko segment's too small. If it's neither tumor suppressor nor lethal, it'll be a normal-sized Blaschko segment, right? So in a lethal gene, things like child syndrome, IP, you have skinny little Blaschko segments, and the skin itself looks atrophic. They look like red stria at birth, and then become yellow-orange as the fat accumulates in them. And because it's a lethal gene, anything that's affected, you lose things. So it goes through your jaw, you lose teeth. Goes through your hand, you lose fingers. Goes through your brain, you lose brain matter, right? Whatever's affected, it's lethal to all the tissues underlying. Some basic concepts that, when you're in clinic, it's very easy to tell, what's a lethal gene, what's a tumor suppressor gene based on the clinical manifestations. No, go ahead. You got the same bug I have.
Is it conoidal
Yeah, cornoid lamellae.
porokeratosis?
So porokeratosis, and these are multiple all over the legs. And so, the clinical sounds like DSAP, disseminated actinic, superficial actinic porokeratosis. Okay, how about that?
Another specimen. There's a lot of fat in there.
There's a lot of fat in
Pretty
there.
high up.
So first, you want to know what the clinical was, right?
Yes, please.
Is this something like a nevus lipomatosis? But this is a little girl with missing fingers and teeth
Yeah.
and one small eye and red stria all over her body at birth, and now they're getting yellow.
Pretty bad gulps.
That sounds like Galt's, right? How old's your patient?
It's pretty young.
How do you know?
Kind of the collagen.
Yeah. Small, red staining, very fibroblastic collagen. So that's kid skin. Right? And so tell me about this kid.
Kind of some whorls of hyalinized material in the dermis, kind of being IP.
So you say in the dermis.
Or in the epidermis.
In the epidermis. Okay, so in the epidermis, you have multiple dyskeratotic cells. So early IP, you're going to see spongiosis with EOs. Later, you may still have a few EOs, and you start to get the dyskeratotic cells. And then late stage IP is the hyperpigmented streaks with pigment incontinence, which gives the disease its name. Okay, got lots of repeats in here.
Looks like you have a collection of, those look like mast cells that you're pointing to.
So down here, you have lots of EOs, right? So lots of eosinophils. These are probably Langerhans cells,
Okay.
which goes with a spongiotic process, right? So early spongiosis, you get Langerhans cell granuloma. And this Langerhans cell granuloma also has some EOs in it.
So not a secondary stage of IP.
So looks like vesicular stage of IP, except that over here you have what?
More dyskeratosis.
Yeah, acantholytic dyskeratosis. So this is actually Grover's, and Grover's, you can have any pattern of acantholytic dyskeratosis. You can also have eosinophilic lesions. That's common in Grover's.
I see dyskeratotic cell.
You see dyskeratotic cells.
Maybe IP.
So multiple dyskeratotic cells, whorls in the epidermis. Given that this is kid skin with EOs, it's probably incontinent to pigmenti. If this were an adult or even a child with evanescent urticarial lesions, sky-high sed rate, then Stills could look similar, but Stills usually doesn't get the eosinophilia. But Stills looks very similar to the verrucous stage IP. Doesn't get the keratoacanthoma like glassy acanthosis, though.
Capsulitis using dyskeratosis.
Acantholysis, maybe some dyskeratosis. Tell me about the dyskeratosis.
See red rings, and it's kind of acanthotic.
Red rings, and it's kind of acanthotic, so more likely Haley if the rings are only ever red. And how are you going to treat Haley?
You can give them naltrexone, you can ablate it with CO2.
So CO2 ablation, if you still have an ablative laser, we've all gone to non-ablative or fractional resurfacing. Fractional doesn't work for Haley. Has to be complete ablation. You have to force it to reepithelialize from the follicles in order for it to work. You can still do that with dermabrasion, or some people still have non-focused mode of non-fractionated CO2. Naltrexone, and naltrexone's usually used at low or high dose.
We used it at high dose, but I think the study was like 1 to 2. But
So studies have been both, actually, the
Okay.
full range, and we need more, doing more research into it. If you have intermittent blockade of opioid receptors, your body responds by creating more and more and more opioid receptors, so low dose can actually potentiate the number of opioid receptors and their activity, whereas high dose really blocks down. And studies are mixed in terms of the dose that's been used. And so we're going to be initiating dose ranging studies for different conditions with naltrexone. It's being used now as an anti-inflammatory. It's being used to prevent acantholysis. And those, when you look at your receptors and how they function, for some you may be better off with low dose. For others you may be better off with high dose. And so that's research that really hasn't been done that we're going to start on.
This looks very similar to the other one that I had.
It does look very similar. So similar, in fact, that it may be the same. And let's see. I just want to see if there's some key others here that we need to hit before we go to potpourri.
Looks like compact hyperorthokeratosis. There is a granular layer. It's not
terribly thick, but
Yeah.
it's present. So, ichthyosis vulgaris, a little less likely. You'd want to look at the patient. If the patient has ectropion and widespread erythroderma, then you'll probably congenital ichthyosiform erythroderma. If they're more plate-like scales, then it may be lamellar ichthyosis. What if the patient looks pretty normal in the summer and just horrible hyperkeratosis that's a dirty brown scale, but only in the wintertime? And it's a guy.
X-linked.
That's X-linked. And then what can you tell me about how he probably came into this world?
C-section.
C-section. Why would he have been a C-section?
Because mom lacks steroid sulfate.
Because if you don't have steroid sulfatase, your mom doesn't go into labor. Right? And so you're born as a C-section. Okay. Let's move this aside. Can I ask you to put those others back in that box? And we are going to switch to potpourri. Okay, fasten your seatbelts. Okay, where did we leave off? Jaco is here. So Jaco is in the building,
Best behavior.
which means you carry on with doing the right thing, which you do every day, right? When you're downstairs, those heading to clinic, please make sure that there aren't piles of slides sitting by the scope, unlabeled, right? And remind the nurses to double check that everything has current dates on it.
I think they were doing all their checks on Friday. Yeah, they're good.
And one would think that they would do that every day, because if you do it right every day, then you don't have to panic when Jaco arrives, right? Okay.
The cells are pretty pink. It looks granular with
You have this little wreath of nuclei, and then it's lipidized to the periphery of that wreath. And there's another one like that, and another one, and another one. Anyone want to jump in?
JXG.
Yeah.
What if you giant cells?
So they look like Teuton giant cells, right? Wreath giant cells, lipidized peripheral to the wreath, and it tends to be the periphery of the lesion that has most of them. In this case, your collagen's pretty red, so your patient probably is juvenile, right? What if your patient isn't J?
It's just
And it's just an XG, then it's just a xanthogranuloma, right? We say JXG, juvenile xanthogranuloma, but not every patient's juvenile who has it.
What if they got it when they're a kid, but they present later? You still call
Say
it
again?
JXG?
I'm sorry?
If they presented if it was present when they were a kid, but they presented to your clinic later.
No, that's a good question. I'll have to ponder that one. Okay.
Looks like a pincus tumor.
Looks like a pincus tumor. Why does it look like a pincus tumor?
It's like an astomosing pink strand.
That was easy.
Yeah. So a anastomosing pink strands, blue buds. How does it differ from infundibulocystic BCC?
It's kind of more of a radiating pattern.
Yeah, those radiate outward from a central follicle. These anastomose. So pincus tumor, very good.
It's like melanocytic proliferation.
Melanocytic proliferation.
Goes pretty. There's a face med goes pretty high up. Trying to see if it matures down. That area looks like it matures pretty good to me.
That area looks like it matures. How about this area?
That area scares me a little bit.
That area should scare you
So
a
maybe
lot.
A melanoma and an nevus.
That's exactly what it is melanoma arising in a nevus. So this area, you have, so first off, you have the ordinary looking nevus over here. It gives you bilateral asymmetry at scan. There's asymmetry of pigment, asymmetry of the epithelial component. This population neither matures nor disperses. It runs along the adnexal structures. There's confluence of melanocyte. It involves the arches. So if you remember, melanoma is your arch enemy, right? It is in the arches. And you have these long parallel trabecular-like walls, which is a parallel theque pattern of nests, which is all melanoma.
Oh, it's a biopsy from the ear.
It's a biopsy from the ear, and it is?
And then there is a CNH.
Yeah, chondrodermatitis nodularis chronica helicis. So you have crust, ulcer, vertical column of fibrin, granulation tissue on either side, not too prominent in this case, and you do not need to see the underlying collagen. And if you do the biopsy properly, you in fact should not see the underlying collagen, right? Unless you're at the VA.
They won't call. They say in the reads they say there's no collagen present, therefore
cartilage.
Oh.
Everyone's doing it.
Oh,
Call it. See if it-
sure you can.
But we know.
Yeah. Okay.
We know.
So how's what do you see?
There's diskeratosis with nuclei with a blue halo or
Some are blue, some
rings.
are clear.
Yeah, blue ones and
So it looks like. So they're not just red, right? They're blue, clear.
Grover.
So Grovers, Derriers, but if this is a solitary lesion, then
She knows that diagnosis.
yeah, correct. So, as Victoria said, warty dyskeratoma. So warty D, warty dyskeratoma is a solitary cup-like or crateriform or expanded follicle-like lesion with acantholytic dyskeratosis.
Squamous cell?
Yeah, it looks like
Really
squamous
differentiated.
cell. Very little epidermal involvement. Could be just plain a section, right? In this case, this is a metastatic squame, which would also be a reason to have very little epidermal involvement.
Cyst-like structure.
Cyst-like structure, and what's in the wall of the cyst-like structure?
Papillary structure.
Yep, papillary fronds,
So-
Roman arches.
So pita.
So if it's dorsum of hand or foot, PETA, which stands for papillary eccrine adenoma / tubular acrine adenoma. If it's head and neck, probably just benign cyst adenoma. What if it's on the eyelid? This does not look like eyelid skin, but what if it were on the eyelid?
Should be cautious for the mucin produce and the mucin producing.
Well done. Someone pass that easy button over here. Okay, go ahead.
Thank you.
That was easy.
So, endocrine mucin-producing carcinoma begins in a hydrocystoma. The wall starts to become complex. It starts to look like a cystadenoma, but on the eyelid, that can be a continuum with mucinous carcinoma. And they tend to be synaptophysin positive, so they're called endocrine mucin-producing carcinoma of the lid.
There's a big dermal nodule with concentric fibrosis,
Big dermal nodule.
and a lot of small blue cells.
Okay, how about these little round clear things?
Those ducts.
So they're ducts, and then how about this stuff? Where you have a vascular lumen in the center and this osteoid-like stroma around it.
I'm not sure what we call that. I'm worried about something like porocarcinoma.
Yeah, either poroma or porocarcinoma, right? So up at the surface, looks like poroma. In the dermis, it looks like a hydradenoma, which is also a type of acrosporoma. This osteoid-like material around the vessels is the characteristic poroma stroma. Right, so poroma stroma is osteoid-like material around blood vessels. Anything in the acrosporoma poroma group, they never palisade. Right, so you never have palisading. You typically have little round, clear spaces. If it has cellularity like the normal acrosyringium, it's benign. If they're packed blue nuclei, as this has in areas, then you start worrying about porocarcinoma. So this probably has porocarcinomatous change in it, where it becomes just too blue. Right? Too many nuclei.
proliferation.
Melanocytic proliferation. Matures and disperses at the base. Matures and disperses at the base.
Pretty big nest down.
Pretty big nest. So no, it doesn't mature, nor does it disperse at the base. Symmetrical in terms of the proliferation? Maybe, not too asymmetrical. Symmetrical in terms of the epithelium. Does this epithelium look like that epithelium? No. Symmetrical in terms of pigment? No. In terms of host response, there isn't a lot of host response in this one. There are some areas of pagetoid scatter in the overlying epidermis, very irregular shaped nests. So this is correct, melanoma. I don't think I'm infectious at this point. I think this is all.
Yeah, Shane's got it.
All just post-infectious crud.
Atrophic epidermis.
Atrophic epidermis. How about your keratin layer?
Some hyperkeratosis.
Some hyperkeratosis. So hyperkeratosis, atrophic epidermis. How about your dermis?
Looks kind of like hyalinized.
Hyalinized. Some might say sclerotic.
Some velocity, that band.
And then there's a band, lymphoid band. So this is an LS and A because you noted the atrophy. If it's not atrophicus, then you just say LS, right? Because some of it, especially vulvar, is very hypertrophic where people scratch it and rub it. How would this histology differ from radiation dermatitis?
Even more time with the radiation fibroblasts.
So you may have radiation fibroblasts. What else? Lymphoid band completely lacking in radiation dermatitis, ectasia of superficial vessels, radiation elastosis that forms vertical columns where the hair follicles used to be, and an absence of adnexal structures. Right. So those are all the things that differentiate radiation dermatitis. Superficial morphia, deeper sclerosis, deeper perivascular lymphoplasmacytic nodules, and lacking the superficial lymphoid band. So radiation, ectasia, radiation fibroblasts, no band, loss of adnexal structures, vertical columns of elastosis would be differentiating features. And with the presence of lymphoid band, you are correct, that is lichen sclerosis. So a little.
No. I see. Parametric coma.
So it has a pattern of scroll-like pattern similar to a pilomatricoma, but is it undergoing pilomatrical keratinization or is it undergoing abrupt keratinization with
Proliferative pattern?
Very good. A proliferating pilar cyst that has broken through to the surface, right?
Yes.
Have you, at conference, have you all seen the kibbles and bits slide? The guy who, when he turns sideways, you can't see his head because there's this massive thing that looks like a pizza dripping. It's a proliferating pilar tumor that just exploded outward. And kibbles and bits because his wife's dog would pay no attention to her. It followed him around waiting for the next chunk to fall from the tumor. Yeah. They can grow very, very rapidly. Okay, so on that happy note, how about this?
Schwann.
schwannoma, because it's encapsulated with a subcapsular crescent zone of edema.
Does on the left side, yes. That total is edematous there.
Anything else this could be? It's certainly a round marble, right? And I see little vacuoles,
More like smooth muscle.
like smooth muscle. So this would be then
I guess leiomyoma.
what type of leiomyoma?
Deep. Maybe there's some vessels there. So
Yeah.
angiolioma.
Angioleiomyoma is the one that looks like a marble, right? So angioleiomyoma, very good.
We have a lot of debris.
A lot of debris inside
Some kind of cystic structure.
inside a cystic structure, and then tell me about the wall of the cystic structure.
It looks pretty similar to like the overlying skin.
Looks similar to overlying skin with hair follicles
Yeah.
and eccrine glands. So this is
I'm just thinking of the EIC.
it's a
Is it a dermoid?
it's a
because of
dermoid, and if you were playing Jeopardy, you would get credit for phrasing it in the form of a question. So very good.
Cells look somewhat. Is that like calcium in there?
So there is calcification.
They kind of look somewhat gray. I would say probably melanocytic.
What if they're epithelial and they're forming these little paisley tie or tadpole-like structures?
So paisley tie differential.
So paisley tie differential, I have calcification. I'm a young woman, and this is a donut-shaped lesion on my cheek.
Desmoplastic. Trichoepithelioma.
Desmoplastic trichoepithelioma, DTE, but I lied. I'm actually a kid with Down syndrome, and these are lots of little things under my eyes. Syringoma, but I lied. I'm actually a 50-year-old man, and this is an expanding red plaque on my upper lip. Microcystic adnexal carcinoma, but I lied. I'm actually an 80-year-old man with a progressive scar-like lesion on my forehead. Morpheoform BCC. So what we have learned is I am a liar, and that the clinical pathologic correlation is necessary for the paisley tie lesions, which may be the more important lesson here. So either an oblique cut or a cylindrical worm-like patient, right?
So it looks like we have extensions from the epidermis.
So hanging down from the epidermis, palisade or no palisade?
No, but it has a nice lining.
So I'd say palisade, yes. And beyond that palisade, a little pink line. So this is?
Trichomoma.
Trichomoma, very good. Multiple trichomomas inherited as part of Cowden's, correct.
So pilometricoma.
So pilometricoma, why pilometricoma?
Or ghost cells in there.
So there are ghost cells, correct. So shadow cell or ghost cell keratinization of the basaloid epithelium. So pilometricoma. Multiple of those most commonly associated with?
Gardner. Or
So
myotonic dystrophy.
myotonic
Sorry.
dystrophy, and went in an EIC with Gardner's, and then we just had one with another trisomy that had not been reported before. So Dr. Winley will be reporting that. So a novel association.
Superficial perivascular infiltrate. It looks like you got at the junction, you got some lymphocytes lining up. Some fibrosis, potentially like MF.
So if there were fibrosis, you might think of mycosis fungoides. Tell me about the infiltrate around the vessel. Is that MF-like?
It's a little more bottom heavy, I guess.
It's more bottom heavy, right? MF, it should be a bare underbelly and top heavy, right? So that doesn't really fit. How about the fact that there are dead reds in here? Does that go with MF?
Not really.
That does not go with MF either. So dead reds, EOs if present, none present in this case, strongly against MF. The primary cutaneous cytotoxic, aggressive cytotoxic T-cell lymphoma can give dead reds, but those people don't last long, right? They expire with a TEN-like presentation pretty quickly. And this had a little bit of papillodermal fibrosis suggesting some chronicity. So any other kind of chronic interphase dermatitis that you know of?
Could be like connective tissue.
Could be like connective tissue, and this person
Or
had
fixed
it
growth.
on their upper back and over their knuckles.
DM.
So dermatomyositis in that case, which again would be clinical pathologic correlation, and we are at the end of the hour. You are welcome.
I have the card.
Just giving.
Oh, yeah. They locked it up.